Your last ECG was normal. Your cholesterol numbers were acceptable. Your cardiologist reviewed your file at your most recent appointment, nodded, and told you to keep doing what you were doing. You left that appointment feeling reassured, feeling like someone with a handle on their health, feeling like a person whose heart is fine. And perhaps it is. Perhaps everything is genuinely well. I hope that is the case. But I need to tell you something that most cardiologists do not have the time to explain in a standard appointment. The tests and measurements that define a normal cardiac workup are extraordinarily good at identifying established disease. They are significantly less good at detecting the kind of slow, progressive, silent stress that precedes that disease by years. The kind of stress that shows up not in a 12-lead ECG or a fasting lipid panel, but in patterns of symptoms so subtle, so easily attributed to aging or tiredness or life, that millions of people carry them for years without once connecting them to their heart. 8 of those patterns are what this video is about. 8 warning signs that your heart is operating under silent stress that most standard cardiac workups will not catch, and that most physicians never think to ask about directly. Some of them will be familiar to you. Some of them will stop you cold. All of them are worth understanding before your next appointment. My name is Dr. Favor Clinton. I have over 10 years of clinical experience in internal medicine and cardiovascular health. And the conversation I am about to have with you is one I have had, too late, with too many patients who had been carrying these signs for months or years and had never been given the vocabulary to recognize what they meant. Today, you get that vocabulary, all 8 signs. Let us begin. Before we go through the 8 signs, I want to explain why silent cardiac stress is such a persistent blind spot in standard medical care. Because without that understanding, you might reasonably wonder why, in an era of sophisticated medical technology, so many people are still arriving at cardiac emergencies without warning. The answer comes down to the difference between what standard cardiac testing measures and what it misses. An ECG measures the electrical activity of the heart at a specific moment in time. It is excellent at identifying arrhythmias, acute injury patterns, and established conduction abnormalities. What it does not detect is the slow stiffening of the arterial walls, the gradual reduction in cardiac reserve capacity, or the early stages of heart muscle fatigue that precede measurable ECG changes by years. A lipid panel measures cholesterol fractions in the blood. It identifies one risk factor for cardiovascular disease. It does not measure inflammation, arterial wall thickness, endothelial function, or the dozen other variables that collectively determine how much cardiovascular stress a heart is actually under on a day-to-day basis. A blood pressure reading taken at a clinic appointment captures one moment in one controlled environment. It misses the morning surge, the nighttime non-dipping pattern, the exertional spikes, and the variability that tell the full story of what a cardiovascular system is managing across 24 hours. The 8 signs I'm about to describe fill the gaps between what standard testing captures and what a heart under silent stress is actually experiencing. They are the signals that show up in everyday life, in the bedroom and the bathroom and the living room, that no clinical measurement routinely looks for. And they are the signals that, when recognized and reported, can redirect a patient's care before a crisis, rather than after one. I want to tell you about a patient I will call Desmond. Desmond was 67 years old when he came to see me, referred by his GP after a routine blood pressure check revealed readings that were higher than expected for a man on 2 antihypertensive medications. He was a retired logistics director, precise, organized, and genuinely engaged with his health management in a way that impressed me from our first conversation. Desmond had passed every standard cardiac test his GP had ordered in the past 3 years. His ECG was normal. His echocardiogram from 18 months prior showed no structural abnormality. His cholesterol was managed. His GP had no specific concern beyond the blood pressure trend. When I sat with Desmond and spent 40 minutes taking a detailed history that went beyond the standard intake questions, asking specifically about the 8 categories of symptoms I'm about to share with you, the picture that emerged was dramatically different from the one his test results suggested. He had been experiencing 6 of the 8 warning signs. 6. Each one, taken individually, had seemed explainable, attributable to aging or tiredness or the natural changes of life in the late 60s. Together, they painted a clear picture of a cardiovascular system under significant and progressive stress. We adjusted his investigation pathway significantly based on that conversation. What we found changed his treatment plan in ways that his test results alone never would have prompted. Desmond told me afterward that he had mentioned several of these symptoms to his previous doctors over the years. They had each been addressed individually and dismissed individually. Nobody had ever asked about all of them together. Nobody had ever taken 40 minutes to connect the dots. The dots were always there. They just needed someone to ask the right questions. Today, I am asking them for you. This is the sign that is most universally present in patients with early cardiac stress and most universally dismissed as simply getting older. The fatigue I am describing is not the tiredness of a long day or a poor night of sleep. It is a specific pattern where ordinary, familiar activities that were manageable 6 months or a year ago now leave you noticeably more fatigued than they should. Walking up a flight of stairs that you have climbed hundreds of times before and needing to pause and recover at the top. Carrying groceries from the car to the kitchen and feeling a heaviness in your chest and arms that lingers for several minutes afterward. Completing a morning walk that used to feel easy and finding that you need to sit down when you return home in a way you did not need to 6 months ago. The mechanism is cardiac reserve reduction. As the heart comes under increasing stress, whether from early heart muscle stiffening, from elevated filling pressures, or from arterial resistance that requires more work with every beat, the buffer between comfortable everyday function and the heart's maximum capacity narrows. Activities that previously fell comfortably within that buffer begin to approach the edge of it, and the body responds with fatigue as an early warning that the reserve is shrinking. This type of fatigue is different from renal anemia fatigue and different from thyroid fatigue in a specific way. It is exertional. It is reliably triggered by activity and reliably relieved by rest. If you have been noticing this pattern, a reliable relationship between specific activities and disproportionate fatigue that was not present in the same activities a year ago, that pattern deserves a conversation with your doctor that goes beyond a thyroid test and a full blood count. Breathlessness during vigorous exercise is expected at any age. The shortness of breath that signals cardiac stress is different. It appears in situations that should not produce it, becoming noticeably short of breath while walking on a flat surface at a normal pace. Finding yourself slightly breathless when bending down to tie your shoes or pick something up from the floor. Noticing that you need to take a breath partway through a sentence when speaking at a normal conversational pace. Waking up in the night with a sudden feeling of breathlessness that passes when you sit up, a condition called paroxysmal nocturnal dyspnea, which is one of the most specific signs of cardiac fluid pressure changes available. The cardiac mechanism behind unexpected breathlessness is elevated left ventricular filling pressure. When the left ventricle of the heart becomes stiffer or weaker, it requires higher pressure to fill adequately. That elevated pressure backs up into the pulmonary veins, the vessels that carry blood from the lungs to the heart. Fluid begins to seep into the lung tissue, and fluid in the lung tissue produces breathlessness, particularly when lying flat, when bending, and when the body is asked to perform even mild exertion. Many people dismiss this symptom as being unfit or carrying extra weight. For some people, that is the correct explanation. But for adults over 60 who have not changed their fitness level or their weight significantly, and who are noticing new or worsening breathlessness in situations that previously caused none, the heart deserves to be part of the investigation. We discussed ankle swelling in the context of kidney disease in an earlier video. But ankle swelling is also one of the most consistent and most overlooked signs of right-sided cardiac stress, and it is worth understanding specifically in this context. When the right ventricle of the heart is under stress, whether from elevated pulmonary pressure, from valve dysfunction, or from the early stages of heart failure, it loses the ability to pump blood forward efficiently. Blood begins to back up in the venous system. The veins of the legs become congested. Fluid leaks out of the congested venous capillaries into the surrounding tissue. Gravity pulls that fluid to the lowest point of the body during upright activity. The result is ankle and lower leg swelling that is most pronounced at the end of the day after hours of upright activity, and that is reduced or absent in the morning after a night of lying flat, when gravity has redistributed the fluid back into the circulation. This morning reduction and evening accumulation pattern is a diagnostically important feature that distinguishes cardiac edema from other causes of swelling. The clinical test for this type of edema is pitting. Press your thumb firmly into the swollen tissue for 10 seconds and release. If the indentation persists for several seconds before filling back in, that is pitting edema, and it warrants prompt medical evaluation with specific attention to cardiac function. Most people experience occasional awareness of their heartbeat. A single strong beat after a fright, a flutter after too much coffee, a brief racing sensation after climbing stairs quickly. These isolated, clearly provoked, brief episodes are generally benign. The palpitations that signal cardiac stress are different. They come without an obvious trigger. They last longer than a few seconds. They occur at rest, particularly when lying down at night. They may feel like a fluttering, a skipping, a sudden racing, or an irregular bumping in the chest. And they recur, not constantly, but regularly enough to have established a pattern over weeks or months. Recurrent palpitations in adults over 60 can represent several underlying cardiac conditions that are worth identifying early. Atrial fibrillation, the most common arrhythmia in older adults, frequently presents first as intermittent palpitations that come and go. Because atrial fibrillation is episodic, a standard ECG taken between episodes will be completely normal, which is exactly why so many cases are dismissed for months before a recording happens to capture the arrhythmia in progress. Palpitations can also represent ventricular ectopic beats, which are extra heartbeats that originate outside the normal conduction pathway. Occasional ectopics are common and often benign. Frequent ectopics, particularly those that occur in runs or that are associated with dizziness or near fainting, can indicate underlying structural cardiac stress that warrants investigation. If you are experiencing recurrent palpitations and your standard ECG has been normal, ask your doctor about a 24-hour or 48-hour Holter monitor recording, which captures your heart rhythm continuously over an extended period and is far more likely to catch intermittent arrhythmias than a single clinic ECG. We touched on orthostatic hypotension in our discussion of morning habits, but its presence as a recurring symptom throughout the day, not just in the morning, carries specific diagnostic significance for cardiac stress that extends beyond the morning window. When the heart is under stress and its pumping efficiency is reduced, the body has less reserve to compensate for the rapid blood pressure drop that occurs when standing. The orthostatic reflex, which normally adjusts blood pressure within seconds of standing, depends on adequate cardiac output to function. A heart with reduced reserve cannot respond as quickly or as completely, and the result is that blood pressure drops more steeply and recovers more slowly, producing the gray, dizzy, momentarily unsteady feeling that many older adults have learned to simply manage rather than report. Orthostatic hypotension that occurs consistently and reliably every time you stand, that produces significant dizziness or requires you to hold onto furniture, or that is associated with any episode of actual loss of consciousness, is a symptom that should never be normalized as simply part of aging. It is a cardiovascular and neurological sign that deserves formal evaluation, including a lying and standing blood pressure measurement, which takes less than 2 minutes and is one of the most informative, simple tests available in cardiovascular assessment. This is the sign that Desmond found most surprising when I asked him about it. He had been waking up once or twice a week, not from a nightmare, not from needing the bathroom, but from a vague sense of unease, a feeling of being unsettled, an anxiety without an object. He had attributed it to stress and the adjustments of retirement. He had never mentioned it to his doctor. Nighttime waking with unexplained anxiety or a sense of unease can be a manifestation of nocturnal blood pressure surges, of arrhythmic episodes that occur during sleep and self-terminate before the person is fully awake, or of brief episodes of reduced cardiac output that trigger the stress response before the brain is conscious enough to identify a cause. In some cases, it represents the beginning of nocturnal angina, reduced blood flow to the heart during sleep that does not reach the threshold of chest pain, but triggers a stress response that wakes the person. This symptom is almost never volunteered in standard medical appointments because it does not fit the classic cardiac symptom description that most people have been taught to watch for. Chest pain, arm pain, jaw pain. Those are the dramatic presentations. The quiet, anxious, unexplained waking that leaves you lying in the dark feeling unsettled without knowing why is the presentation that gets missed. If this is happening to you regularly, please describe it to your doctor in precisely those terms and ask them to consider a cardiac cause alongside the psychological ones. A cough that you have attributed to a postnasal drip, to mild asthma, to the dry air in your bedroom, or to a lingering respiratory infection from months ago. A cough that is consistently worse when you lie down at night and that improves when you sit up or stand. A cough that produces a small amount of frothy or white mucus. This specific pattern, a cough that is reliably worse when lying flat and that produces frothy sputum, is one of the classic early presentations of pulmonary congestion from left-sided cardiac stress. When the left ventricle's filling pressure rises, fluid seeps into the lung tissue. In the upright position, gravity keeps that fluid toward the base of the lungs, where gas exchange is less impaired. When you lie flat, the fluid redistributes throughout the lung tissue, impairs breathing, and triggers a cough reflex as the body attempts to clear the airways. This symptom is consistently attributed to respiratory causes. People take antihistamines, use nasal sprays, buy air purifiers, and spend months treating what they believe to be an allergy or a respiratory problem, while the actual cause, elevated left ventricular filling pressure from early cardiac stress, continues unaddressed. If you have a persistent cough that is reliably worse lying down and that no respiratory treatment has resolved, please ask your doctor to include a cardiac assessment in the investigation. This is the sign that requires the most self-awareness to detect, because it is not a symptom you feel. It is a number that changes gradually, over months, in a direction that is easy to miss if you are not specifically tracking it. But for adults over 60 who monitor their pulse, whether through a home blood pressure cuff, a fitness watch, or simply by checking manually, it is one of the most informative early indicators of increasing cardiac stress available. A resting heart rate that has been gradually increasing over months without a corresponding increase in physical activity, without a new illness, without a change in medication, and without an obvious cause, is the heart telling you that its workload is increasing. A heart under more stress beats faster at rest to maintain adequate cardiac output as its efficiency or reserve begins to decline. A resting heart rate that has moved from the mid-60s to the mid-70s over 12 months without explanation is the cardiovascular equivalent of a car engine that has to run at higher revs to maintain the same speed. The speed looks the same, but something has changed under the hood. If you have access to resting heart rate data from a wearable device or from home blood pressure monitoring, look at the trend over the past 6 to 12 months rather than the most recent reading in isolation. A gradual upward trend over that period, without explanation, is worth bringing to your doctor specifically and asking them to consider in the context of your overall cardiac assessment. 8 signs. Fatigue that is disproportionate to the activity that triggers it. Shortness of breath in situations that should not produce it. Ankle swelling that accumulates through the day and is most pronounced by evening. Palpitations that recur without an obvious trigger, particularly at rest or at night. Dizziness or lightheadedness when standing that is consistent and significant. Unexplained nighttime waking with anxiety or unease without a clear cause. A persistent cough that is reliably worse when lying flat. And a resting heart rate that has been gradually climbing over months without explanation. None of these signs alone is diagnostic. Each one has multiple possible causes beyond the heart. But I want you to do something specific right now before you move on from this video. Think honestly about the past 3 to 6 months, not last week, the past 3 to 6 months. How many of these 8 signs have you been experiencing with any regularity? If you are experiencing 2 or more of these signs consistently, I am asking you directly to bring a specific list of them to your next medical appointment. Not as a general mention in passing, as a prepared, specific list with how long each symptom has been present, how frequently it occurs, and what makes it better or worse. That level of detail transforms a brief mention into a clinical signal that a good physician will take seriously. The investigation that may follow from that conversation, which might include a 24-hour blood pressure recording, a Holter monitor, an echocardiogram, or a cardiac stress test, could identify something that a standard annual check would not. And identifying it before a crisis changes everything about the options available for managing it. I want to hear from you in the comments. How many of these 8 signs have you recognized in yourself? And has any doctor ever asked you about all 8 of them together in a single appointment? Write your honest answer below. I read every comment, and the patterns I see in those answers help me understand what this community needs most from the next video. If this video gave you something important today, something you are going to bring to your next medical appointment, please share it. Share it with the person in your life who has been dismissing symptoms for months and accepting them as aging. Share it with anyone over 60 who has passed their last cardiac workup with a clean bill of health and assumed that means there is nothing more to watch for. That assumption is the most dangerous one in cardiovascular medicine. Subscribe for more honest, research-grounded conversations about protecting your cardiovascular health after 60. Next time, we are going to talk about the 2-minute bedtime routine that lowers blood pressure overnight without medication. It is simpler than you expect and more effective than most people believe. You will not want to miss it.